So let's do it. Okay. So let's get started. So good afternoon, everyone, and welcome to this third session edition of the ePAG Exchange of Good Practices. So for those who don't know me, I think there are some of you. So my name is Anne-Laure. I've joined EURORDIS in March earlier, 4 months earlier, as a patient engagement manager. So I work together with Matt, Ines, Concha, and Lenya as well. So I'm supporting 8 different ePAGs, and I'm also coordinating the communication aspect and the exchange of good practices across the 24 ERNs and ePAGs. So as you know, I don't know if you already attend the previous sessions, but we had already 2 sessions, 2 calls in January, I think, and in March on exchange of good practices. And we had the meeting in Bucharest as well. Some of you attended. Alex, sorry, can you mute? Thank you. So we discussed different topics and area from very different ePAGs and ERNs. So patient journey, we had the clinical patient guidelines, training, education, governance as well, ontology, and registry. I think I have got the ones. So they are available on the website, as you know. And today we are going to focus only in one single area presented by Anke. We are going to focus on the consensus statement. Okay, the next session, the next one will be by the end of the year in November 15th. And we expect to have at least 3 good practices to share with all of you. So the session of today will be, we're going to start with Anke's presentation during 30 minutes approximately, and then the rest will be for question and answers. So don't hesitate to share your views, to make any comments, to ask questions, or whatever you need to exchange as well, and to start a discussion among the group. So I will start by thank you for your participation. We are nearly 30 participants, which is great. People are still arriving, so welcome. Thank you in particular to the ePAG ERNICA and Anke. She's been working a lot these last weeks, putting together all these fact sheets and all this gathering all this information and so on. So thank you very much for your time, Anke. So Anke Widenmann, is it well? Widenmann-Grolig. She's an ePAG advocate since the very beginning, actually. She joined the ERNICA at the very beginning. She's a member of the ERNICA board as well. She's a treasurer of the EAT Federation, and she actively supports one of the working stream. This is the disease-specific working groups in ERNICA on the diseases of the esophagus. Okay, so she's working in doing this fact sheet, this presentation, together with the other members of the ePAG and the working stream, Graham, Slater, and JoAnne Fruithof. So they three of them participated also in the elaboration of the fact sheet. Petya, sorry for that. I will try to mute your audio. Okay. Okay. Okay, so Anke, I give you the floor if you would like to start.
Thank you very much, Anne-Laure. Can you hear me?
Yes.
Yeah. Okay. So I will mute now my video and will share the screen with you. Hello, everybody. I hope I hear my voice from somebody else. Maybe everybody is muting the microphone until we have the questions. Thank you. Just a second. There we are. So hopefully you see now my presentation. Yeah? Okay. Wonderful. So Anne-Laure asked us for a good practice example, and Graham and we decided that the consensus statement is a very good example for how patient involvement is not only participating, but really creating additional value on a consensus statement. In our case, it was the surgical consensus statement for esophageal atresia. This is in ERNICA one disease, and at this level I want to thank Carmen Dingemann. You will see later that some of the slides are from her presentation. She is a clinician and she had the main workload in writing all those consensus statements together. Simon Eaton from UK, he's a scientific and clinical researcher. He did a lot of the technical work, and Benno Ure is our work stream coordinator within ERNICA. So without them, I couldn't do this presentation. But first of all, EAT. Who is EAT and what are we doing? EAT is a federation of all support groups for esophageal atresia. We were founded in 2011 with a lot of... Excuse me? Oh, okay. With the support of Frédéric Gautran. He's a clinician in Lille, France. He asked us whether it's not a good idea to have a European federation. We are international, but mainly European, and we have 7 board members. So, and for the picture, I come back later. It's a great success of collaboration, but this later. ERNICA is, I guess, what the smallest ERN. We only have 20 hospitals or HCPs from 10 countries. We were a little bit a last-minute ERN because initially they were a bit skeptical about it. So you see here the coverage. We are lacking of countries in the eastern part and in the deep south, so Spain, Portugal, and so on, but as well Poland, Czechia, they all are missing. And René Wijnen is the coordinator of ERNICA. He's in the Erasmus Hospital in Rotterdam and a pediatric surgeon. ERNICA is the European Reference Networks on Inherited and Congenital Anomalies. We do have the esophageal disease, where the esophageal atresia is one of them. We have intestinal diseases, intestinal failure, gastroenterological diseases are new. We didn't work on this till now. And the malformations of the diaphragma and the abdominal wall. So it's mainly a topic for newborns at the moment, but step by step we get the congenital anomalies which come later in life, for example, the achalasia. So you see here, this was the picture of our third ERNICA yearly conference in Padua this year, and the red circles are the patient representatives, and I think we are not too bad. We are a small patient group, but compared to the number of hospitals, it's not too bad. You see in the esophageal disease, it's Graham, JoAnne, and myself, and we are all from different countries, UK, the Netherlands, and Germany, but we are all working together since 2011 within EAT. Then we have Annette and Nicole for the intestinal disease, and there we have a cross-link to the ERN Urogen. The intestinal failure, we had 2 patient representatives. Unfortunately, they are not yet convinced to continue. For the new area, we haven't found an ePAG yet. And for the malformations of the diaphragma, we have Beverly and Fanny and probably another Italian guy. So hopefully we are better off there as well. So that's probably something you all know. We have next to the disease-specific work streams, the network activity or working packages. In all of those where we have the key activities in the first 3 years, ePAGs are involved in every of those working groups. This is now one of the slides from Carmen, where we describe why we did think that a consensus conference is important. We had meetings from April 2017 until April 2018, And whenever we talked about our diagnosis, esophageal atresia, we realized there is little evidence on anything. So we had neither for the diagnostic nor for the therapeutical concepts, we had any real evident information. So there was a leakage of a generally accepted guideline or algorithm how to treat those patients. So actually everybody is doing whatever they want to. This is the main thing. And so we decided in our work stream for within ERNICA that we will prepare a consensus conference on the perioperative and surgical management of those patients, which mean that those newborns have to be treated within the first few days of life. What we as patients thought is as important as the surgery is the follow-up after the first release from hospital, because we know that many of the difficult situations for the families start only after then. So we are very proud that we managed it to get the follow-up into this consensus conference in Berlin 2018. So if I look at it, what were the additional values already in the preparation of all this was that we managed it to get the follow-up and a little bit the transition already in this first consensus conference into the discussion. We could bridge the gap between those consensus statements and all the topics we as patient representatives see as needs of the families once they left the hospital. And on this topic, we ePAGs had the lead because we decided to offer the patient journey to manage them. So we have some clinicians who are working together, but it's us who have the full overlook over the process. We invite the clinicians, we decide when we meet, we decide the topics and the agenda. And so we work here very close together, as Carmen Dingemann, who's doing the consensus statements very close, is as well in our patient journey group. So what we could do then, we could use all the results in the consensus conference later for our patient journey. So avoiding double work. So this was Berlin in October 2018. This was the group of 19 people doing this consensus conference. And again, 3 circles. That's myself, then Graham and JoAnne amongst the clinicians. And this picture is really like this. I think finally they didn't even think of it that we are patients. So we had 19 participants from 9 countries and 3 patient support group representatives from 3 different countries. So we had quite a good coverage as well from different health systems. So how did we prepare the conference? Now it's getting a little bit technical, and just to say, later I will state a little bit about the lessons learned. I never ever could imagine how much work it is to take 15 well-trained people together and decide what might be a best practice consensus statement. So it was really amazing for me how much work was to be done initially. So for example, the first step, the literature research done by Carmen Dingemann, Simon Eaton and Benno Ure. So this was really a very clinician and scientific work where we as patients could hardly do anything, but they just looked up where is literature. So we had something between 2,000 and 3,000 publications on this topic. And so what they did, they generated items due to a very scientific process out of those, they first said, okay, not all of them are relevant. And so they had to reduce the number of literature work. And from all the literature they found it is relevant, they generated items. Those items were presented in Stockholm on our ERNICA meeting in April 2018, including us 3 patients. representatives, and there we decided, okay, how will we do it? How do we group the items which are really important, that we could stay, that we didn't have more than 100 items, because more than 100 items in 1.5 days, you can forget about it. So we had to prioritize.
Anke, sorry to interrupt. Can you just briefly put an example of what an item is so that people understand?
Okay.
Items?
Yeah. Those are, I come back later, but those are items, for example, that you are asked, a spontaneous breathing should routinely be favored. Just as, so, which is not always easy with our patients, but they stated this and the surgeons agreed all on it. Yeah. Or a central venous line should be routinely placed preoperatively. There we didn't get the consensus because the surgeon thought, no, it isn't. So they really looked up in literature about which topics they talk. They did this. They had 8 different sections: the diagnostic, the preoperative management, the operative management 1 and 2, the postoperative management, the follow-up in 2 groups, and various. So a few things which couldn't be took into those things. So, and then we had those sections. And we had, I don't know, 120 items approximately. So we had a first online anonymous voting with RedCap, I think, where we could, on a 5-point like scale, say it's relevant or it's not relevant or something in between. So with this prioritization, we prioritized 82 items in total. And this was then the final list where we went to our workshop in Berlin in October 2018. So this I showed already. So we have grouped, and what we did then, for every group, we had 2 clinicians and 1 patient representative who looked up in the literature which was relevant for this topic, and then we had to check, is it evident or not? Can we use it? So we had small groups of 3 people preparing for each section a first statement from the point of view of literature. So this was the preparation work in total we had to do before we could travel to Berlin, which obviously was quite a bit of work. Even when Carmen and Simon really did all the work, and the number of literature was shrunk to something between 200 and 300, we as patient put in our own leaflets and said, this is literature as well. It's a different type of thing, but there we develop flyers and leaflets and information sheets for our members and patients due to the needs they give us. So if we have 10 times the same question, we develop a flyer. And so this was one item as well, especially for the follow-up later. No. So this was the work done, and then we met in Berlin for the voting consensus conference, including us 3 patient representatives. Maybe it's important as well that all the clinicians got paid the hotel by ERNICA, and the patients got paid the flight as well. So the clinicians had to pay, or the hospitals paid the flights, but for the patients, we got our travel costs reimbursed. I think this is an important point, because the clinicians didn't pay it privately, but we have smaller and bigger communities. So, and then it started. So we had, for example, back again, we started with diagnostics. Then the person who was in duty for the looking up the literature made a small presentation about what we discussed in our small group. And then the voting for every single item started. And on every single item, we had discussions. Sometimes, especially if we didn't have consents, the points why we didn't get we didn't have consents got explained. So if you look later up in the whole set of consents meeting, the whole documentation, you not only have the voting, but you have the discussion about what did the clinicians talked about. And this is sometimes even more interesting, especially so for the people who didn't attend the voting can look up how we worked, what were the arguments pro or against a consensus. And we as patients learned a lot. So it was an anonymous voting. So we had a system. Everybody had its own laptop, and we had we could score between 1 and 9, or we could say, I don't have an opinion on it. I think this is key, that patient representatives can participate, because on many items we are not specialists. I can't say with which type of stitches you sew an esophagus. That's not my competence. So it's interesting for me to know, but I can't decide whether how to do it. So the 100% for a consensus depended on how many people really voted. If you didn't have an opinion on something, you didn't vote. So you will see this later, that we have different numbers, which is for when do we have consents. And
Anke, sorry to interrupt you. There is a question from Edward regarding the anonymous voting. He's asking why the process of item selection was anonymous.
As far as I understood, I was told in a scientific, valid Delphi process, this is key, that it is anonymous to avoid bias like, oh, he's my friend, I can't be of another opinion. So this seems to be, I'm not an expert on Delphi processes, but we were told this is key. If you do a Delphi process with open voting, you might have biases because of a personal relationship, or when somebody is not so sure about and he's following the majority, then you have a consensus pro, although maybe there is more discomfort with the situation than the voting would give up. So I had really the feeling it was good. And they even didn't see who said, I'm not competent. You will see later, not only the patients did say sometimes I'm not competent. We had doctors who used this instrument as well, which I think is great. And I don't know whether they would do this if it wouldn't be anonymous.
Anke, you're completely right. You get very strong personalities in the clinical world. You know, professor such and such, or, you know, and when they speak, it influences the other people if they're certain about something. So they exert their personality a bit, and that does have weight. So this anonymous enables it to be independent, and that's very important.
Yeah, thank you. So, So this is an example how we've seen it, let's say, seconds after the last person voted. So Simon had his system. He didn't see who voted what, but he's seen whether all the 19 participants either voted or said, I have no opinion on it. Otherwise, we couldn't go ahead. So you couldn't cheat. And then we always looked up this result, and then we went to the next question. That's just an example. This question wasn't discussed because it vanished with the prioritization. So this is just a technical, just to show you what Carmen and Simon did in advance from those 2,000 or 3,000 literature works. They had 116 relevant publications, and only 4 had really a level 1 evidence study. So just to see how less evidence we have and how we had to work. Yeah. So, and then the conference started, and I have just encircled some examples on which topics for us patient representatives it was interesting, although we didn't have an opinion on it. So whenever you see 15, the 3 patients said we don't have an opinion, plus a clinician. Yeah, we think we know who it was, but it's not important. He just said, I'm not competent in it, and he discussed with it in very narrow things. And here even 2 clinicians said with the 14, I'm not competent in it. Yeah. So, but here the last one, for example, during pre-operative counseling, parents should be routinely informed about different surgical options, such as open and thoracoscopic repair. There we voted because this is very important for us patients, that we think it's not a good thing that the surgeons say, oh, I'm the best, I do it like this, and the parents don't get information that there might be a different way of treating, and then it's not going well. They are calling us, and then we must tell them, well, there are newer, better, less invasive possibilities to treat your child. And then it's a second traumatization for the parents, because they think, oh, hell, why didn't I know this? Yeah. So there we have a very strong opinion on it, and we know about it, and therefore we could vote. So that you see the differences. But we couldn't work on riblocal tube, yes or no. I mean, we know what it is, we know that it's routinely placed, but we didn't know whether it's necessary, but because some people say, oh, we don't need this. So, but now we have consensus from the best surgeons. Listen, it is routinely to be placed, and now when families call us, we can say, listen, this is consent statement of the best hospital in Europe we have. So this makes the work for us patients really much, much easier. The same with the operative management. You see there are very many items where we didn't vote, but we wrote it, for example, here. That we have from time to time those parents, the child is born on a Saturday morning and then surgery is done on Sunday, and on Monday we would be available and then it's done. And we know that it's urgent to do the surgery, but it's not an emergency case. So this is the difference. Yeah. Or here, the question 27, again, we said, yeah, that's important, that if somebody says, I'm doing it minimal invasive, he should have a expertise on this, and not only saying, oh yeah, let's try. Yeah. So those were, for us patients, very, very important points. And we are proud about the last one, the 52, the clinical checklist for before first discharge, because some of the surgeons tend to tell the parents, oh, now everything is fine, we'll see you in 3 months, or when something happens. And they don't tell the parents what might happen. And then the child gets blue the first time while drinking, and then you really have a problem. So we think it's important that it's not our duty as support group, it's the duty of a surgeon and his team to inform the parents what might happen and what to do. An emergency. So this is very, very patient born. This one is just because I wanted to show you in the second part for the follow-up. You see here we have many 18s. So this is the part where we are much competenter in, because many of the parents or the children don't get a good follow-up in their hospitals, and then they are calling us. So I guess in some topics we know more about how to learn feeding, how to learn eating, what to do with a certain situation in the kindergarten, in school, than any clinician. So we have very strong moments on this. We have on top one, there should be a structured schedule for lifelong follow-up. This means it's not just a follow-up for a week, a month, a year, but lifelong, which is for us now the key for transition talks. And this was great for us as well, that we now can say to the patients, listen, here there is consensus that an esophageal atresia patient needs a lifelong follow-up. This is now consented amongst the experts. Why I can't show you everything, it's not published yet. So the second part will be published. It's written. It's at the moment we are doing the correction, and it will be published by the end of the year. So if anybody is very interested, please contact me. You get it as soon as it's there.
So Anke, what is it? It's something has been published now. What is it?
Yeah, I show you.
Part 1 or what?
Next slide. Published was the first part. So the diagnosis, the preoperative management, and the operative surgery. It was published in the Pediatric Surgery Journal in June, and it's gone now online. I sent the link to Anne-Laure. It's not free available. You just can see the summary, but it's now in the online. You can buy the guideline. So if anybody wants to read it, he can contact me, but officially I can't publish it somewhere. So, but what's important about the publication is that you see the red circles again. You have to read very carefully that you can see that we are patient supporter, patient representatives. We are just in this list of 19 people. And I think like all the other clinicians who worked on it. So, and I think it's okay because we did as much work as the others, maybe even a little bit more. So what are the success, or maybe before I go now to the success factors, are there any questions concerning the methodology and how we did it with the voting? No? No. Okay. Then maybe later. For us, if we look back, and I talked to it with Graham, why did it work? It worked, first of all, because of the support of the coordinator. I know that in other work streams, there is one patient representatives in this consensus statement thing. So it was up to the coordinator who said, okay, you can have those 3 places. We even had a 4th one. Unfortunately, the colleague couldn't come. So then otherwise it would have been 4 out of 20, which is amazing, I think. We had and have a very positive relationship on national level, for example, with Carmen Dingemann, who gave me a very shorthanded all her slides that I could use them for this presentation, but as well in other countries, in the UK, so or in the Netherlands, wherever we have patient groups, we have very close contact to the important experts on surgical level. Then I guess it's that we have soft skills amongst us ePAGs, and they are recognized by our clinicians. For example, JoAnne, she is a veterinarian, so she is medical treated, even if it's for dogs and cats. Still, she has a very good understanding about how everything is working. And then JoAnne and myself, we are doing since more than 10 years counseling for our membership families. So this is, I think, important as well, because if you don't know what is important for our patients, it's difficult to put it into the patient journey or into a consensus statement. And Graham is, from his business level, somebody who is well trained in keeping a project managed. And I think sometimes our coordinator is a bit suffering because he's asked about what's the timing, what are the packages, when do we deliver? So it's the patient who pushes sometimes. And we as ePAGs, I think is very important that we come along together very well. If there's any question left, or no, we don't have this, you know, it's like we know the other person would never do anything which harms me. We trust into the good intention of everything what they are doing. And if there is something I don't understand, I ask. We never had on ERNICA topics any hassles. We have sometimes different opinions, but we don't fight on anything. So I think that's key as well. And now the wonderful thing is we have this guideline, or those consensus statements, which is not a guideline. I learned, that's one of my lessons learned. We can disseminate it. We will disseminate it in every country where we have national groups and beyond, because we have TOFS, the UK group, has members in 55 countries. So we might reach patients in Eastern Europe or Southern Europe country who are not member of ERNICA today. So this is that's now really a patient possibility to push all the other hospitals in those other countries, at least to reach this. Whether they obey it or not, it's the other question, but at least they can't tell afterwards, I didn't know, because we will tell them. And so the fast dissemination already started. We had in June the OPSA Congress, that's the European Congress of the Pediatric Surgeon, which took place in Bucharest, I guess, and Carmen already presented the guideline there. And we had last week on the fifth World Congress of Esophageal Atresia in Rome, the presentation of the results of our consensus statements. Which was interesting, the reaction, especially of our American colleagues. They were quite, how shall I say? They couldn't follow that we got something like this in Europe. So they were impressed. Lessons learned. I don't know whether we could have done all this without 10 years of EAT work and a very good knowledge of all the partners we had in there. Probably it's working as well, but it really helps, you know. Because the clinicians had to trust us that we don't abuse our votes to do anything bad with it. So they really trusted us. And they know how we work, they know how we are, and that's probably why they offered us this without that we asked for it. So for them, it was clear we can do this with those patient representatives. The second lesson learned was it's because myself, I was thinking of doing more European work, more ePAG work, less in our national group, because I do have here my mobile. I have the 365-day hotline for our patients. I thought to ask other people to do so, but I won't do it because I need those information. This is really key, that you know what's the most important for our patients in every single step of their patient journey. It's different if you have a newborn or a kindergarten child or a school child, or later when you are adult and you have your transition to do. So you either need this knowledge yourself, or you need a good team around you. Like Graham, he's not doing this counseling, but he has a very good team around him. So you need those information. Maybe this would be a topic for EURORDIS, how we can get those information well collected, because not everybody has the time like me to do both, and sometimes it's getting a little bit too much. And one key thing is that our coordinator supports in a very profound way the patients, and he's setting the tone in ERNICA. And whenever Graham states on our meetings, oh well, René, you didn't inform me in advance, and he say, guilty, I'm so sorry about it. So we have to think about it, that we have to inform the clinicians as well. It's not only in the one direction, it's in the other one as well. Because I think we get from EURORDIS so many informations that sometimes I have the feeling we are better informed than the clinicians. So it's giving and taking a little bit. Yeah. So this was lessons learned 1. Oh yeah, I promised you to show you, excuse me, but do I have time? Sorry, but I have to talk about this. this man here. We invented the first Esophageal Atresia Award, EVA. This has to do with this trust and the acknowledgement that those clinicians are working in their spare time. Frédéric Gautran, he asked us patients in 2009, don't you want to have an international federation? And we said, yes, why not? So he connected us, invited us 2010 for the first World Congress of Esophageal Atresia, and there we founded EAT. So without him, we wouldn't be prepared in this way for the ERNICA project. So he got our EVA. It's this little statue here, and he's the first medical person who get this prize. And we will give it every third year when we have our World Congresses. There will be a special person who get this prize, just that you know. And this is one possibility to acknowledge the work of the clinicians. It's not only us who's working for free, who are working without money, who are working for the fame, for whatever. It's them as well. And if they realize that we acknowledge this, I think it's good for relationship and trust. And my personal lessons learned was, Jesus, this methodology is complicated. And I never thought in advance how much work there is until you can do this voting. I thought, well, we go voting. So I learned a lot. And maybe some of the pieces we can use for this, what are really patient-relevant information. I think about it. There are the tools. There's this online voting. We could use this internally amongst patients as well. So this is lessons learned. But the other thing is, a consensus statement is the first level of evidence. So it is better than just any publication. So we are very proud and very happy that we do have this. And therefore, I want to thank all the clinicians who participated for all this work in Berlin. And we are going ahead. We will have the second workshop on the much more complicated and rare long gap type of esophageal atresia in November 2019, again in Berlin. Thank you very much. I hope I gave you a little bit of an idea how we worked, what we did, and that it's really worth doing it. Thank you.
Thank you very much, Anke. Thank you so much. I think it was a very clear presentation and very precise and with a lot of examples, and definitely a very good example of collaborative work with clinicians and patients. So thank you very much for that.
You're welcome.
Very well done. Thank you very much for that. So we still have 20 minutes.
Just Anne-Laure.
Yes, sure.
But I want to mention, dear colleagues, without Anne-Laure, this would have been impossible. She helped me to structure it. She helped me with the wording. So it's,
and Ines as well.
And Ines as well. So it was really teamwork all together. Yeah.
Thank you, Anke. Thank you. Yes, Matt?
Can I ask a question?
Yeah, of course.
Anke, are you thinking about drafting something like a layperson's version for families and for parents? Because the process sounds great and your outcome sounds great, but what are you doing to make that more accessible to your community?
Yeah, so the first one is now the clinicians get the guideline or the consensus statement. They should be able to read it, but then we will try to convert it into little pieces, because for a family having a newborn just before surgery, they don't want to talk about follow-up. So we started already in Germany and in all the other countries that we have a leaflet for the newborns, a leaflet for the first time at home. So step by step we have it. So and the next step will be now first in English to translate it into patient language. And then we have to translate it into the other language, which will be no problem in those countries where we have a support group, which might be difficult for the other languages. But I understood we get support for this by the EU. Yeah, this this is key now, because we have the two slides of dissemination. On the one hand side, the clinicians, and on the other hand side, the parents. Yeah.
There's a software called DeepL.
Yeah, I know.
Yeah,
I know.
It's quite good for the first translation.
Yeah. But it's still work to clean it, because we used it for some translations of a children's book, and maybe this is special because you need another language for children, but still, it's still work. Yeah, we have to put it on many heads. Yeah. Any others?
Oh, hello, Anke. This is Ian here from MPNE. I wondered, when you build these consensus status, how do you handle particularly sensitive issues where there's a lot of contention? Because I can see that being a stumbling block for us. I recognise it's just a consensus, but what do the people who have lost their point of view, who've lost the argument, as it were, how do they react? How has that been resolved?
I think that's one of the big advantages of the anonymous voting. Nobody knows who it was. There was no, I mean, in some questions, they stated, oh, I don't agree there, but if you say so, I accept it. But there weren't many, there were no tensions, because we had in total, we had a lot of consensus. And and some of therefore we had those, what I didn't show you now, you had the possibility to put your own vision or your own point of view into this comments. So they could tell in the comments why they didn't agree, and it is published as well in the official guidelines or in the official statements. So those comments were then the possibility to state why they didn't agree on it. Yeah. So so either I didn't get it, that they were having hard attacks afterwards, or we didn't have it. I mean, there were some points who were controversial, but they weren't very emotional, I would say. No. It was more afterwards that some who didn't attend had their the question, why did you consent on this and didn't do on this? So. But I didn't hear a lot of difficulties. No.
Can I ask one more question? How did you ensure you got a representative sample? Because one of the concerns we have in our, subdomain of our EUROCAN group is that if we don't get a representative sample whilst building consensus and building appropriate guidelines, they lose authority. Because people say, well, you didn't get anyone from this clinic, why should we listen? And that's something we're trying to look to the future and perhaps being overly worried about. I don't know yet.
Well, we will know this maybe by next year. Eventually, we have in the big countries like Germany or UK, we have really the hospitals who are known even in the national community as the expertise center. In the Netherlands, we have the four who are doing the surgery. The others are not allowed to do this, so there is consensus as well. I could imagine what you're saying, that this will be in November a little bit different, because we definitely have no consensus of how to treat the long gaps. And one proposal from our side was, as long as we can't decide on one of those, we have two different surgical approaches, and we did it this way, that we said, as we don't have evidence about if the one or the other is better, we will have a consensus voting on both procedures. And then the patients can decide whether they want the one or the other, but they have the restriction and how to do then this procedure for both procedures. So this might be a solution as well, because if you don't have evidence on either or, you must say, why not describing both and consenting on both procedures, and maybe about the restriction and for one patient the one procedure is better and for the other one the other. And so if this is described, we can as patient counsel our families much better. So this might be, if there is really a very controversial topic where you don't have evidence, you must support the clinicians to get to evidence. And you only get to evidence if you describe then both methods, and then the next 5 years they are doing both, and maybe then we can see which one is the better one. No? So I don't think I have another solution for your problem. Was this clear what I wanted to say?
Yeah, yes, it was. Thanks, Anke. I think that's in the nature of rare diseases, that evidence can be hard to come by.
Exactly.
And it's often used as a stick to beat us with when we get something where all the common sense and all the top clinicians or experts will say, yes, this is the way to do things. And someone will say no, because there's no, peer-reviewed paper on it. Well, of course there isn't, because there is. I expect everyone experiences that.
Yeah. But if 80% are doing then due to the consensus statement, and they can prove that it's better than doing anything else, then we will have evidence. It will take time, but already, which is important that we already have now at least the best practice we know today for our patients, and not wait until we have evidence. Because how to produce evidence? Only if you have comparable procedures, you will get evidence. So it's a little bit like the cat cutting its own tail. Yeah, I don't know if you have an English proverb for this.
Yeah, no, that's the same. Yeah.
Okay.
Yeah.
Okay.
Okay, thank you.
You're welcome. Okay.
Could I just add about the consensus statement methodology? The next big thing in all the ERNs will be to develop guidelines and consensus statements. So the Commission are about to award a tender in the next month for a consortium to come in to support all 24 ERNs. And the task will be over the next couple of years to develop 2 new guidelines or consensus statements from scratch, and identify 5 consensus statements or guidelines which are existing ones for assessment, adaptation and adoption. So that's 7 guidelines per ERN. And the consortium will, when they come in, will take the methodology similar to what Anke explained and come up with a set process, a standard methodology for which all ERNs will follow in developing a guideline or a consensus statement. And therefore that will include and cover off about this, ensuring that there's a consensus of the relevant number of people for the guideline to adopt it and to follow the network to follow the guideline or consensus. So the work is about to happen. This network's a bit ahead of the curve.
Okay.
Matt, it's Ian again. Sorry, I just wanted to ask, when you say guidelines or consensus status, are you talking about one in lieu of the other? So if in place of guidelines, one might instead have a series of consensus statements.
If there is a body of evidence, then there is a methodology called grade to grade that evidence, and then you can develop something called a guideline.
Yeah.
For the vast majority of rare diseases, it's 1 in a million people affected, and therefore there's a lack of robust published publications to use that methodology. So therefore, there is a greater need probably for our community to develop consensus statements. The commission are calling them clinical decision support tools. That's the language, the terminology they're using instead of consensus statements. So each network in the next 6 months will be asked to prioritise which 2 new guidelines or consensus statements they will develop from scratch, identify the areas of greatest need, and the patient involvement in that decision making is important. And the second one is to identify existing ones. It might be the German consensus statement for, I don't know, for something, and then the network would use that, assess its quality using agree to, because that assesses the robustness and the independence of the process which that was developed originally, and then identify what the gaps are and update it based on the network's opinion. And that would be, and there's 5 of them, so that's 7 new guideline stroke consensus statements in the next 2 to 3 years.
Yeah.
Each network, that's a lot, times 24.
Yeah, and no, that's very useful to know, actually. Because one of the issues with us is our particular subdomain within EUROCAN didn't start up until quite late, because we had a change of the clinical lead.
Which one?
So we barely got involved in the initial guideline. But you're saying that in addition to that guideline that we're working on, there will also be this new initiative now to build something from scratch, be it consensus statements or guidelines.
Yeah, so ERN Gentauris has been developing guidelines and stuff at the moment, and their thinking was for Lynch and for hereditary breast and ovarian. There's a lot of published guidelines already. So what they did was they looked at rarer conditions like TP53 or Li-Fraumeni, which are very rare, and there's nothing out there. So therefore, they decided to develop guidelines for those conditions from scratch, because nothing was in existence. Whereas the other ones, they're identifying what's currently out there for hereditary breast and ovarian and Lynch stroke polyposis, and then looking to seeing which ones they prefer, assess the quality. So they're sort of going through that process. So it will continue. The guidelines and consensus statements are the next big thing politically. So when Anke and ERNICA have got this in place fully, the fact it's an ERN document, the value of that is yet to be demonstrated. Will it have greater weight in the 28 member states for adoption? So we're going to see the proof will be in the eating of the pudding, but the political focus and the funding is being put in for all the networks to prioritise guidelines to show their added value. So it's a big ticket item for us.
Yeah, that's really useful to know some of that stuff. That I can bring that back to our group. Yeah, okay, thank you.
It's Ilaria speaking from ERN Reconnect. First of all, Anke, congratulations, because you made a huge work, and it will be very interesting to share with other not in the call today. And in our experience, it is really useful for the development of new guidelines to liaise with the scientific society, of course, because maybe they can endorse and not, it's a political issue, as Matt mentioned, because otherwise they feel out of the loop, and it would be a negative impact. And to develop something liaising with the society is always better. And as I read also in the Charissa comment, is because we are in the same ERN and we share the same issue. The HCPs, which are not in the ERN, so not directly involved in the development, would feel excluded. And ERNICA, as you said, as well as Reconnect, are very small ERNs. And we need to widen the experience as much as possible. And, Matt, would you explain a little bit better what you said about the same methodological approach for all the ERN, please?
So just to say that the next call for new members of the network probably will be launched in September. So that will be to broaden out the networks in terms of coverage. The consortium who will come in from the Commission to support all 24 ERNs will do a literature review of what is the evidence-based approach for developing guidelines and consensus statements, like the Delphi approach or grade or agree. And also look at how the networks are currently doing it, like ERNICA, what's the policy in place, what's the process they've used. They'll also come up with what's the model for expert opinion overseeing that guideline development. the model of the experts. You know, should it be covering at least 5 member states? Should it be having someone from the professional society involved? That will all be defined in this piece of work, and it will be defined in the first 6 months. The professional societies have a really important role to play, and a lot of the networks are still fostering that relationship with their European professional societies. And the more that the networks build that relationship with their professional societies, the better then when a guideline or a consensus statement is in development, that those bodies are engaged to have ownership as well. But this has always been a political thing between clinicians, and there's a lot of competition, etc., etc. But we have to be inclusive in our approach and our methodology. So it will be taken into consideration, including international consensus. So there's nothing to stop involving people internationally in this.
Thank you very much, Matt. I'm just reading the chat. Charissa is making a comment. What about international consensus? With some diseases, international is more important than European, as much as most experts are outside of the EU. So I don't know if you want to say a word on that, or we can continue the discussion in another moment, or.
A lot of the networks have been engaging with people internationally because of the expertise for that condition, and that's fine. It doesn't have to be just experts within the network. It's an ERN-led initiative. You can involve wider clinical groups. There's nothing to stop you on that. There's no rule to say you can't, but it is an ERN initiative, these guideline developments. So it's for them to engage or to go through a process of engaging more broadly or in an international basis as the guideline is developed.
Thank you very much, Matt. I think we're going to take the very last question from Elena, and then we can close the session. So could you please, okay, Elena, could you please stop sharing the screen so Matt, when you speak, it's easier to understand. So sorry, Anke, can you please stop sharing your screen? Thank you very much. Okay. So any other comments or questions regarding the very great presentation made by Anke? No? So thank you very much.
Oh, yes. I couldn't unmute. This is Renee.
Mm-hmm.
I was just thinking about everything that's being said just now about who is involved in the voting. And so I started thinking back, who were the 19 people? Are those the only healthcare providers involved in this ERN? Or were they selected, or who were present at the conference to vote?
So there was a call within ERNICA that every healthcare provider could send one person. So we wanted to have a broad coverage of all the HCPs. We had hospitals who are in our ERNICA network, not for the esophageal atresia, but for another malformation. So they gave their place to somebody else. So we had experts for the gastroenterological thing. He's not usually in ERNICA, one of the participants. So it was the HCPs in ERNICA who decided who will be sent.
Okay, thank you.
You're welcome.
Thank you very much again, Anke. You see on the chat, you are a lot of thank you. Now we are 37 participants, so thanks a lot again. So as I told you, we're going to share the presentation and the recording on the website. Okay, I will send you the link, but basically when you can see the section on good practices on the EURORDIS website. We're going to have the last session of exchange of good practices in November. So please feel free to already send some ideas. We already gathered some good examples that we're going to share. We're going to have 3 or 4 for the last presentation of this year. So please feel free to send your ideas, your good practices, even some example of not that good practices, could be also a good example of how we should improve or we do things differently. And I think thank you again for attending the call, and yeah, and I wish you a very good afternoon and see you very soon. Thank you very much, everyone.
Bye.
Bye. Bye.
Thank you.
Bye.
Bye. Bye.